This presentation is about parenteral nutrition, or TPN, which stands for Total Parenteral Nutrition. You might also have heard this referred to as hyperalimentation. The driving question for this content is what must an RN know about nutrition and parenteral IV therapy to safely administer TPN? The definition of TPN is a complex intravenous therapy to provide complete nutrition. So notice it's intravenous, it's given through the IV line, and it has three primary nutritional components: proteins, carbohydrates, and fats. We'll talk more about each of these elements in detail in the following slides. These three elements maintain balance in the diet, help people stay strong and healthy, and they support the immune system. Now, we aren't always aware that we're consuming these elements, especially the other components that are included in TPN, such as electrolytes, which can include magnesium, potassium, sodium, iron, phosphate, trace elements, which can contain selenium, copper, or zinc, and vitamins, which can be A, B, C, D, or K. Pretty much everything that we get in our normal diet that we're not even aware of. And it also includes water, and sometimes it includes medications. So TPN includes all of these elements in a liquid solution that's transfused into the venous system. TPN is very hypertonic. It has a higher osmotic pressure than the cells around it, so it pulls fluid from cells and causes them to shrink. And so one of the main nursing considerations when administering TPN is monitoring fluid volume. So the first nutritional element that we'll talk about more in detail is protein. Proteins function to maintain the structure and facilitate wound healing, and they maintain muscle. So this is why athletes and bodybuilders will often try to increase protein in their diet. Protein's really important because when there's not enough protein in the diet, the body will begin to burn and waste muscle. It's composed of amino acids, and a typical TPN solution contains 3 to 5% protein, but it can sometimes contain up to 20% protein, and this is for patients who have had significant muscle loss or weight loss or need major wound healing, since protein is an important component of wound healing. The next element that we'll talk about are carbohydrates, which function to provide energy for the body, and in fact, they provide 70% of an individual's daily energy needs. They're also essential for central nervous system functions. Because they provide so much energy, this is why you'll commonly hear of athletes carbo loading the night before a big athletic event, such as a marathon. The final composition of carbohydrates in TPN is about 25%, and this is classified as a hypertonic solution and needs to be infused through a central line, as opposed to a peripheral IV. If you think about it, the common IV solution of D5W or D5NS or D5-NS contains only 5% dextrose, and so comparing that to TPN of 25% dextrose, you can see how much more this is a hypertonic solution. The next component is fats or lipids, and these are 30% of our daily calories, and they provide our bodies with energy. Lipids come, for TPN, they come in either 10%, 20%, or 30% concentrations. Lipids by themselves are nearly isotonic. They come in a separate bottle or a bag from the TPN. They're never mixed in, and you'll see them either in the glass bottle, as you can see on this picture, or in a plastic flexible bag. They are white, they're milky, and they're opaque. They run in the same tubing as TPN, but they need to be below the filter. So we'll talk about TPN needing to be filtered, and if lipids are plugged into the line above the filter, they will actually plug it up and cause problems. and you won't be able to use that tubing for the patient. So you always connect it into the TPN line below the filter or closer to the patient, and you'll see pictures of that at the end of this presentation. One thing to be really careful about is that you cannot give lipids to someone if they're allergic to eggs. So just as with everything else, it's really important to make sure that you're checking the patient's name band and allergies. So we've talked about the three main components of TPN: proteins, carbohydrates, and lipids. And now we're going to talk about some of the other components of TPN. The first of these is electrolytes, and these are added to TPN to meet daily requirements based on an individual patient's needs. So the content is adjusted daily based on nutritional lab values. So someone who's on TPN is going to get frequent blood tests, especially when they first start on TPN, to get a baseline. So you're going to be looking at the basic metabolic panel of the patient to determine what the recipe of the TPN needs to be. For example, if you have a patient with a low sodium, you might expect that they will have a higher sodium in the TPN. Another example is if you have a patient who has high potassium, you might expect to see a lowered potassium level in the TPN. So it's really important that these are monitored and that the TPN recipes are based per individual basis. Another thing that's added to TPN are vitamins, and these include all of your normal vitamins that we talked about at the beginning: A, B, C, D, E, vitamin K. In addition, you'll see trace minerals. These are essential, but in small amounts. Examples of trace minerals include zinc, copper, chromium, manganese, and the other ones you see listed here. You also might see medications mixed into TPN. It's really important to understand that nurses do not add the medications to the TPN. The pharmacist adds it in the pharmacy and then sends it to the unit where it's double checked by 2 RNs. So this can be a really efficient way when a patient has a lot of IV medications or limited IV access, because you can give the medication along with the TPN. Some common medications that you might see mixed in with TPN include insulin, heparin, vitamin K, hydrocortisone, Pepcid, or antibiotics. But like I said, never add a medication to TPN solutions after they're dispensed from pharmacy. It's also important to understand that you never piggyback a medication into TPN solutions. You always run TPN and lipids on their own, and you don't add anything into them. So what's the difference between parenteral and enteral nutrition? On the left, you can see parenteral nutrition. This is a setup with the TPN bag hanging on a pole with some pumps and some other bags, and you'll see the TPN is the bag with the light yellow clear liquid in it. And parenteral nutrition is yellow, clear, transparent. It goes through an IV pump, has a large white label with the recipe of it right on the bag. It should have the patient's individual name, medical record number, and date of birth. And so you might guess that TPN is more expensive. Parenteral nutrition is more expensive because it's mixed up based on individual patients' needs. On the right side, you'll see enteral nutrition. So enteral nutrition is opaque, it's milky, and it doesn't go into the veins, it goes into the GI tract. So you use, it includes tubing that goes through a feeding pump, but goes into the patient through an NG tube, an NJ tube, a PEG tube, or some other such enteric route. So who should receive TPN? TPN is for those who can't effectively use their GI tract for nutrition either efficiently or effectively. So some of the main groups of patients include patients who are receiving cancer treatment, because as you know, chemo can cause extensive nausea and vomiting, and patients might not be able to take food enterically without vomiting, and thus not getting enough nutrition. Certain surgeries, you might see patients needing TPN when they're getting certain surgeries, and this is usually when they need to be NPO for several days, and you don't want to irritate the patient's gut. And and so they will need parenteral nutrition. Another group of patients include those who've had burns or trauma. This causes an increased risk for imbalanced electrolytes and dehydration. And also there can be an altered structure of the GI tract due to the burn or injury. There can also be burns to the esophagus or the intestine or any other aspect of the GI system. The fourth is any type of GI diagnostic, such as an obstruction, a fistula, inflammatory bowel disease, acute pancreatitis, GI bleeds. All of these need to have gut rest so that the gut isn't irritated, but these people might not be able to eat for a long time, and so it's important to start parenteral nutrition. Additionally, any critically ill patient who can't tolerate enteral feedings should be started on TPN ASAP. At Abbott Northwestern here in the Twin Cities, their policy is that once a patient has lost 10% of their body mass, they need to be started on TPN to prevent further body mass loss. So clearly it's important to be checking daily weights and monitoring for that loss. Another common rule of thumb is that if a patient is expected to be NPO for 5 to 7 days or longer, they should be started on TPN. We've been talking about parenteral nutrition, and I've been calling it total parenteral nutrition, but a difference in total parenteral nutrition is peripheral parenteral nutrition. So remember that I said total parenteral nutrition needs to go through a central line because it's so hypertonic, and it would cause severe damage to a regular peripheral vein. However, you can mix up a recipe that's considered peripheral parenteral nutrition, or PPN. So these concentrations must be almost isotonic in order for the vein to be able to handle them. And so the glucose can't exceed D10, so that's the highest concentration, 10% dextrose, versus the 25% that TPN usually is. Lipids, remember, are basically isotonic, so those are the same at 20%. Protein, however, can be a maximum of 3 to 5% rather than potentially 20% in TPN. And then the vitamins, minerals, and electrolytes just need to be isotonic as well. So the advantages of this is that there's no need for a central line. And as you learned a couple weeks ago, there are definitely risks of a central line. So you can prevent those risks if you're able to use PPN. And it's also used for mild deficits. So when you know that the need for parenteral nutrition is going to be less than 5 to 7 days, it will generally be PPN instead of TPN. This is also used when patients can be partially fed through a GI tract, and PPN is considered more supplemental instead of total. So here's a review of the two types of TPN. You can see on the left that central TPN is used for greater than 5 days of being NPO, and it needs to be infused through a central line. You can see on this picture it is the bag on the right, TPN, and it's being infused into the subclavian vein here through a central line. As opposed to that, peripheral TPN, you can see, is generally used for less than 5 days of being NPO, and it's infused via a peripheral IV. So here's our bag of PN, and it is going through the right antecubital, which is just a small peripheral vein. When you initiate TPN, it's standard practice that you always double check it with an RN, with the second RN. So 2 RNs each are checking the bag, and so this is done because the TPN recipe is individualized to each patient, and we need to make sure that the recipe is correct. If the concentration of something is too great or too small, it affects a patient very quickly because it's being infused directly into the bloodstream. So this is done by pulling up the MAR, reading off of the TPN bag, the recipe for each ingredient and each ingredient's concentration. Before you even do that, you should read the patient's name, medical record, date of birth, and make sure that what's in the chart matches what's on the bag. You additionally need to verify the correct rate. After you do this, the two RNs should initial, date, and time the TPN bag. After the two RNs double check the TPN, the nurse needs to prime the tubing, and it's very, very important that you have filtered tubing. At the end of this presentation, you'll see a picture of what a filter might look like, and this filter is necessary in order to filter out any air bubbles, clumps, or sediment that might be present. So after you prime the filtered tubing, the nurse needs to label the tubing and the lumen with the initial, date, and time. Sorry, the tubing should be initialed with the date and the time, and the lumen that the TPN is infusing into should be labeled as the TPN lumen, because you always try to infuse TPN into only one lumen if you have more than one. You need to know whether the infusion should be centrally infused or peripherally infused, and it will always say on the order whether it's TPN through a central line or PPN. For the infusion rate, you always need to use an IV infusion pump and program the rate or the dose. You never use the drip rate and gravity because you need a precise rate, because the TPN is got such varied concentrations of electrolytes, and you can cause damage to a patient if you transfuse them too fast or too slow. So you should have a second RN verify the rate and the dose before beginning the infusion. You should never speed up the rate if you get behind schedule. You can imagine that if you have to speed the rate up because you get behind, and there are things like potassium in the TPN, they might get too much potassium too fast, or if insulin's been added, they might go into hypoglycemic shock because they've gotten too much insulin too fast. So you always stay at the correct ordered rate. Another thing is that it's common to titrate and or cycle TPN when you start it. So you often start it at a slower rate than what it's going to end up at. So for example, you might start at a rate of 30 and increase to 60 or 90 mils per hour after an hour of running. You also never want to interrupt or abruptly DC the TPN, because think about how much dextrose is in that solution. And so if a patient is getting 5 or 10% dextrose, or even in the TPN, it could be up to 25% dextrose. If you stop that suddenly, the patient might get hypoglycemia. So in order to prevent that, if you ever have to stop the TPN or the bag runs out before you have the new bag from pharmacy, you need to start 5 or 10% dextrose at the same rate as the TPN. When a patient's receiving TPN, some of the most important things that you need to be monitoring are daily weights, because as you can imagine, the patient's susceptible to fluid overload, and so INO is also important. We need to document all forms of input and output and be able to check weights to make sure the patient is not losing or gaining too much weight, but that they're maintaining their weight. We need to check the temperature generally every 4 hours because the patient's at increased risk for infection, along with other vital signs that might indicate a problem. We need to be measuring their protein and electrolytes, so frequent lab draws, usually daily at first, which might be extended to every 3 days or even weekly. We need to check their glucose, so usually when patients are receiving TPN, even if they're not diabetic and even if they're not on insulin, we're still monitoring their glucoses every 4 to 6 hours. We need to be checking the infusion site for signs of infection, as well as the IV tubing and the IV dressing to make sure that those are changed when needed. So with the charting, we need to be charting their weight, signs and symptoms of edema because of that risk for fluid overload. We need to be making sure that we're charting their INO and strategies to facilitate PO intake, because we always want to be thinking about transitioning back to oral intake, because the gut can be at rest for too long sometimes, and then it's harder for them to transition back to oral. And so you always want to be thinking about this. Again, we want to be charting their vital signs and temperature, their nutritional status and abnormal labs. This is important that you're watching those labs closely and you're notifying the MD as needed, So if a patient's phosphorus, for example, comes back very elevated and you know they have phosphorus in their TPN, you might want to notify the physician of that. You need to be charting your routine central venous catheter site assessment and care, the dressing change if there's any redness or drainage, and you need to be documenting on the MAR the date, the time, the rate, the site, and 2 RNs' names and signatures. You also need to be charting and doing patient and family teaching. Most people in the community don't know what TPN is, so they need to have it explained to them. The length of time they might be on it, why they're on it, what it means to be NPO, and why they're at increased risk for infection. There are 3 main categories of complications of TPN. The first is infection. So one of the most important things is to change the tubing regularly. This can be anywhere from 24 hours for lipids up to 96 hours for TPN. It all depends on the facility and the type of tubing used. You always need to use that inline filter we talked about. That helps prevent infection because it filters out any bacteria that might be in the TPN, which hopefully never happens. Assessing that IV site for infection and recording temperatures at least every 4 hours. And then never administer medications, blood, or blood products through the TPN line because that increases the risk for transfusion reactions. These things should always go through separate IV sites. That doesn't mean, however, if a patient has a double lumen or a triple lumen central line, you can use those other lumens for something else. But you should always have one lumen designated just for TPN. An additional complication of TPN are complications associated with central lines. So you can get phlebitis or infiltration with PPN because even though it's not as hypertonic as TPN, it is hypertonic generally. Patients can also develop a pneumothorax from the tip of the catheter puncturing the lung or the pleura. This will present as pain, decreased O2 sats, and increased respiratory rate, as well as an air embolus or thromboembolism. The third category of complications of TPN is metabolic complications. So hyperglycemia is rather common because of the increased dextrose in the solution. This can present as thirst, headache, lethargy, increased output, or the opposite, hypoglycemia, especially if for some reason the TPN is interrupted for a short period of time. And this can present as diaphoresis, the patient getting shaky or confused or even losing consciousness. Other complications metabolically are fluid imbalance, electrolyte imbalance, acid-base imbalance, and hyperlipidemia. So again, all of these reasons are why we're checking those labs regularly. So this is a picture of what TPN and lipids look like. There's a pump here to remind you that they always need to be run on a pump. And this is a bag of lipids. So on the slide before you saw what lipids look like when they come in a bottle. This is what they look like when they come in the flexible plastic bag. And here's that clear light yellow TPN. This is what a filter looks like. And so at this point you would unscrew this blue cap and twist that onto your maintenance IV tubing. And then this is the end that would go into your patient. Okay? This is where TPN, or where lipids could connect to, because notice it's below the filter. So if this is coming up from the pump, here are your lipids, and they're below the filter, and then transfusing into the patient. Here's a graphic of what TPN and lipid setup should look like. So here's your lipids, and notice that that's going through a pump. And here's your TPN, that's also going through a pump. And here's our filter. Okay, so notice that our lipids again are connected below our filter, in between the filter and the patient. And this is because those lipids are so thick that they would clog the filter. Here are your references, and that's the end of this presentation.